Okay. Arshu, can we start now?
Good evening, sir.
Good evening. Ganesh has joined.
Ganesh Bhai, let me see, sir. 1 minute. Not yet, sir.
Okay, I'll just telephone him and we can start then. Who is answering today?
Sir, it's Dr. Atul Gupta and Dr. Ekansh Gupta. Both of them have joined.
Okay, Atul and Vikas Gupta, na?
Dr. Ekansh Gupta, sir.
Okay. Ganesh Bakshi is joining in 4-5 minutes. So I think we can. Maheshwari ji, can we start now?
Surely, sir, I'm there.
Start करते हैं. Okay.
Okay, sir. Shall I start?
Yeah, please.
Today's case is of a 75-year-old male who presented with a complaint of intermittent bleeding in urine since 20 days, increased frequency of urine since 10 days, and passage of blood clots in urine since 2 days.
Fine. Okay. So Atul, can you just
Good
tell
evening,
us?
sir.
Yeah, Atul. Now this is the
Yes.
history. How we will
Cannot
extract the.
hear.
How will you extract your history?
Sir, I would like to ask more about the history of hematuria, sir. Meaning, since how many days, meaning duration, is it painful or painless? And types of clots, amorphous or serpiginous, then intermittent or continuous, and how many episodes were there? And does it resolve spontaneously, or anything medication has been taken for that, or any intervention has to be? And how was the urine after this episode of hematuria? And any previous similar episodes were there or not? Any history of anticoagulant is there? Any history of bleeding tendency or a disease is there or not? Like that, sir.
Ekansh, you want to add anything?
Sir, I just wanted to add that
Yeah,
how did the patient present, whether he had he had any symptoms of decrease, palpitations, extreme decrease work capacity, and symptoms of anemia, and second, whether the hematuria was initial, total, or terminal, and third is about painless or painful, and also about dysuria, burning, micturition, other urinary complaints, and associated complaints like flank pain.
See, you people are not very coherent. You have to make your own plan and the history taking, and very fluently you have to finish. This history taking should be like finish in 2 to 3 minutes. You don't have to put more, effort or time in that. So here you will ask about the hematuria. You will ask about the lower unit tract symptoms and associated findings. Now just see how Harshi has given the history. Harshi, finish the history.
Yes, sir. So this is the photograph that the patient presented with. The patient was asymptomatic before 20 days, after which he started complaining of reddish discoloration of urine. It was at the end of micturition, insidious in onset, painless, appearing intermittently with no specific intervals, no specific aggravating or relieving factors. The bleeding was associated with passage of amorphous clots in urine since 2 days, which was insidious in onset, not associated with any aggravating or relieving factors. Patient also complained of increased frequency since 10 days, which was associated with mild burning sensation while passing urine, with decrease in flow, nocturia 2 to 3 episodes per night, and sensation of incomplete voiding. There was no previous history of similar episode. The IPSS score was 13 out of 35.
Go ahead.
There was no history of abdominal pain, no history of lithuria, pyuria, no urgency, incontinence, urinary retention, no previous instrumentation or catheterization. There is no history of nausea, vomiting, fever, no jaundice, facial puffiness, exertional breathlessness, lower limb edema, no history of backache or bony pain, no history of bleeding disorder, anticoagulant therapy or blood transfusion, or no history of radiation or chemotherapy.
Yeah, go ahead. Finish the history and then stop.
There is no significant past medical or surgical history. Family history is non-contributory. The patient has a vegetarian diet with normal appetite and regular bowel habit. Bladder is disturbed as described. Sleep is normal, and the patient has a habit of tobacco chewing since 40 years and is a
Fine. So, Atul, now this is a history. Can you just summarize in 2 or 3 sentences and tell us what is the history and what is your probable diagnosis?
Sir, this is a 74-year male who is presented with intermittent hematuria since 20 days and with frequency and the meaning no with positive he's a tobacco chewer, so it is a positive finding in that history, and will consider as this as a lower tract bleeding because clots shape was there. He told that it is amorphous clot, so I will consider lower tract bleeding. So,
So,
bleeding
can you,
meaning. Hmm.
yeah, can you give me a summarize and tell me the diagnosis?
Sir, most probable diagnosis can be, sir, benign prostatic hyperplasia or vesical stone can be there, and uh, other diagnosis can be because tobacco chewer, he is the tobacco chewer, so can be malignancy.
बहुत सारी गड़बड़
Uh,
हो रही है. I can see Pankaj sir also holding his head. You need to summarize it nicely, and
mhm.
your diagnosis is also going all haywire.
See, first of all, what is the commonest diagnosis? What is the commonest when you get when you are sitting in a OPD when the patient like this comes to you saying that I have got a painless hematuria, okay, and he is showing these amorphous type of clots. What is your probable diagnosis? What which thing comes first in your mind? In your 3 years of practice, or when the patients are admitted, which is the commonest?
Sir, like BPH and malignancy, sir, both.
How many times you see BPH with bleeding like this? Why are you saying BPH? And
So
you
in
are saying
above 60
you
year,
said
it is
lower
most
tract.
common cause
You
of
said
bleeding.
you said lower tract. You said probably bladder. So bladder is definitely more common with hematuria than upper tract. You heard the history now, everything. Then suddenly you're saying BPH. Couple of things are getting missed out here.
Sir, tobacco chewer is more in favor of malignancies.
All urological malignancies are associated with tobacco.
Mm.
Ekansh, can you summarize and tell us what you think and how you are going to put forward?
See, guys, at this stage, it has to come fast. We cannot get stuck in history and summary. It has to, you have to be very fast and fluent, and your thoughts have to flow this at this stage. Otherwise, we cannot reach management. Chalo, sir asked you to summarize. Come on, do it nicely.
So this is a 74-year male presented with intermittent hematuria since 20 days, and he's a tobacco chewer. And my probable diagnosis is bladder malignancy.
It can also be other things. So you can tell the other things, whatever you said.
It can be benign prostatic hyperplasia
It can be a
or
vesicle
vesicle
calculus.
calculi
I would like
or
to further investigate, sir, and I would like to have further investigations to confirm my
yes,
diagnosis.
yes.
Atul, based on history, how do you say benign prostatic hyperplasia?
Sir, no, meaning there is no significant weight loss history is
No, no.
there,
So
and
it can be
appetite is
enlarged
normal.
prostate. What sir is trying to say is benign prostatic hyperplasia is a histopathological diagnosis. Why are you saying that in history? No, enlarged prostate can be due to benign causes or malignant causes.
So, Atul, the major
Yes,
mistake
sir.
that is happening here is that
Yes, sir.
BPH to present with hematuria is extremely unusual. BPH, as you know very well, will present with significant lower urine tract symptoms.
Yes, sir.
His IPSS score was just, I think, 10, 11, if I remember.
13. 13.
Okay. So, when does BPH present with hematuria?
Sir, when highly vascular gland is there and prostatitis, meaning infection, is also associated with that.
So, are you
And
suspecting infection?
um,
So it
sir,
sounds something
because
like
of
a more chronic
frequency,
picture, right? Sir is trying to tell you that it's something like a more chronic picture. This is a short history, no?
So,
yes.
a elderly man presenting with short duration of painless total hematuria with clots.
Mhm.
BPH will always be an additional finding. It will never be your first diagnosis.
Yes, sir.
So in this patient, if you have to keep a clinical diagnosis, it will be bladder tumor as the first diagnosis. Everything else is going to be rare.
Yes, sir.
Okay, how often? Means then what happens is, Atul, you will get counter questions like, how often have you seen BPH with vesicle calculus presenting with painless total hematuria? How does vesicle calculus present?
Sir, if median
So
lobe
no, don't
enlargement
answer,
is there,
don't answer that. What I mean is that your interview will go in that direction.
yes, sir.
Okay, so in this patient with the available information up till now, the only diagnosis we can keep is bleeding from lower tract, most likely bladder tumor.
Yes, sir.
Rest everything, we will be surprised. If this turns out to be only BPH, I'll be surprised. Vesicle calculus, I'm not expecting. And don't ever put a label of BPH, even if there is a classical lower urine tract symptoms, say bladder outlet obstruction due to prostate, could be benign or malignant. On
Yes.
history, how can I make out? How many times have you seen cancer prostate presenting with weight loss? So
Yes, sir.
don't dig a hole for yourself.
Mhm.
You agree with me or you don't agree?
Yes, sir. Yes, sir.
Okay, चले आगे चले. Because you started off well saying that there is a history of tobacco, so I thought you were heading straight towards bladder tumor.
Yeah, and then at that time, if you change it and say bladder stone, then it becomes anyway. You are doing well. Chalo, let's go ahead.
चले आगे चले.
Yeah.
On general examination, the patient is vitally stable with ECOG score of 1. No signs of paler icterus cyanosis, clubbing, lymphadenopathy, or edema. Spine examination is also.
Anything positive in examination, just tell them.
Was grade 3 enlargement of prostate. with firm consistency, smooth surface, non-tender, median sulcus obliterated without nodularity or induration, and rectal mucosa was mobile, rectum was empty.
You mentioned genitals, no, Harshiv?
Sir, on genital examination, patient was circumcised.
No blood at the meatus. Meatus normal. Testes, cords normal.
Yes, sir.
Those
Yes, sir.
things also you
Everything was
mentioned.
normal.
Okay. Yeah.
Yes, sir.
Any urological exam, you cannot miss genital examination.
Okay, so where do we stand now, Atul?
Sir, here prostate enlargement is there. Meaning form inconsistency, smooth, non-tender, median sulcus obliterated, and no nodularity or induration is there.
So when sir
This
asks
is
you this
this is the
question, there is
only
no need to
positive
repeat.
finding.
Listen, when sir asks you this question, there is no need to repeat the examination findings. You just
Yes,
say that, sir, there is a clinically enlarged prostate
yes,
and there is bleeding. So I would like to further investigate. I would
Perfect.
still like to
yes,
further. Yeah.
yes, sir.
So what is the next investigation you want?
Sir, I want to go for complete blood picture and this urine routine microscopy and like renal function test and a liver function test
Why,
and
why
coagulation profile.
LFT? Why LFT?
Sir, if coagulation profile is deranged, then also patient will present with hematuria.
Baba, first you have to talk of ultrasound.
Yes, sir.
Why you are talking about coagulation profile? You want the examiner to take you into coagulation profile? Okay, now tell us coagulation profile in detail. What do you understand by each word? BT, CT, PT. You see where you are taking yourself.
Atul, when is the last time you have advised LFT sitting in OPD?
Uh, yes, sir.
You see, please treat the exam as the routine thing. Don't try to do anything different. If you do anything different, you will fall into trouble.
Yes, sir.
So there is no place for LFT at this time. चले आगे चले.
Okay, sir. Then,
I
sir,
have a
will
suggestion that when you're presenting, we should be able to see you. We cannot be talking to your photo. Anyway, go ahead.
sir, then I'll go for ultrasound, sir. In ultrasound, uh, USG abdomen pelvis with prevoid and postvoid residual. I want, sir. In that, we can comment better if any uh, bladder clot is there or stone is there or any um, wall thickening is there, like that we can comment.
So this is what you will tell your sonologist. So he'll give you bladder wall thickness and prostate size and stone is not there.
So Atul, the better way to say is, first and foremost, nobody asked you why you want a sonography. So better
Yes,
way to say is that sonography will help me localize the site of bleeding,
yes, sir.
whether it is upper tract or lower tract. We are
Okay,
all
sir.
interested in that. Are we going to
Yes.
treat based only on sonography?
No, sir. We'll
Or
further
will we
investigate.
investigate further? So
Yes, sir.
sonography is more like a screening test to localize where is the source of bleeding.
Yes, sir.
So you have asked for CBC, urine routine creatinine, and sonography. Anything else you want?
Yes. Sir, that's all, sir.
That's all. बताइए भाई इतने बता दें.
So around blood reports, hemoglobin was 9.8, total count was 11,800. Platelets were normal, 3,95,000. Serum creatinine was 0.73 and INR was also normal, 1.06. Electrolytes were also normal and PSA was 2.9.
So Atul, do you want PSA in this patient or you don't want PSA?
Sir, PSA, no, not needed, sir, actually.
Not needed. Okay. Okay. Any patient presenting with lower tract disease it is better to get a PSA done. And especially, you see, on your DRE findings, they had said it's an enlarged prostate, firm inconsistency, median sulcus obliterated. So PSA is something better to advise.
Okay, sir.
ओके, चलिए आगे बढ़े।
Yes, sir.
सोनोग्राफी दिखाइए। आई कैन सी अ वेरी वेरी अनफोकस्ड इमेज। सबको वैसे ही दिख रहा है या मेरे स्क्रीन में कुछ प्रॉब्लम?
Sir, focus not there. Sir.
I don't think we can expect them to read these images. You can give the report. Yeah, here probably something is seen. So what do you find here?
Sir, here I can see the bladder wall, and
What is this?
Baba, this is the way you'll
this
present.
is
I
looking.
can see bladder wall. Huh? What's wrong with you? अच्छे से बोलो, ultrasound of the abdomen, pelvis,
Yes,
cavity,
sir.
whatever it is.
So
What all do
this
you
is
see?
so this is ultrasound of abdomen and pelvis, in which image is focused on bladder, urinary bladder, and you can see some bladder wall thickening, and one uh, space occupying lesion is there inside the lumen.
Is it
So that's
inside the
all you
lumen
can
or
see.
attached to the wall?
Sir, it is, we can't comment, right, sir, but it is looking like it is attached to the wall.
Right.
And
So you see, having space occupying lesion inside the lumen is very unusual.
yes,
Other than clot, probably I don't think anything else can be there. So
Or Thor's bulb.
police valve.
yes.
Okay, what else do you find?
Mm. Sir, it's looking like prostate is also enlarged in
Very good.
the,
Can you
and
see
median lobe is
cursor moving?
indenting
Yes.
inside the median lobe is indenting, and left looking like left lateral lobe is also intravesical in there.
How do you make out that left and right?
Sir, meaning probe is on the right, R is written there, sir, and here left is written. Yes.
मुझे तो नहीं दिख रहा है, anyway, ठीक है. Instead of saying median lobe, better to say is intravesical prostatic protrusion.
Okay, sir.
Okay, not everything which protrudes in the bladder is a median lobe.
Yes, sir.
So better term is IPP.
Yes, sir.
Okay. So we have a moderately filled bladder, thickened bladder wall, a mixed echogenic mass arising from one of the wall, enlarged prostate with large IPP.
Yes, sir.
Okay. Report बताइए.
The USG report suggests of
Hold on. हम पढ़ लेंगे. Atul, you can read the report and give us the final findings.
Sir, a positive finding is prostate is enlarged in size with few cystic areas within, measuring 6.2 into 5.3 cross 4.5 centimeter with approximate volume of 78 cc. This is only finding.
अरे ये लाइन में
Rest
क्या है? ये
all
क्या है? Prevoid के ऊपर के लाइन में क्या लिखा है?
yes, sorry. Urinary bladder is distended with mild diffuse wall thickening 4.1 mm and polypoidal irregular lesion of size 14 into 12 mm seen on right infralateral wall.
So when you have a patient with bladder tumor, what all do you want to see? We want to see that both kidneys are normal. Is there
Yes,
any
sir.
lesion in the bladder? Are there any clots
Yes.
in the bladder? Prostate and post-void residue. So
Yes,
सब चीजें देख के बता दे क्या क्या है.
सर राइट किड जो लेफ्ट किडनी है दोनों के अंदर बायलेटरल सिंपल कॉर्टिकल सिस्ट बताया जो कि कैन बी नॉर्मल एंड
So upper tracts normal.
Yes, sir. Upper tracts are normal, and urinary bladder thickening is there. Wall thickening is there with irregular polypoidal lesion with measure on right infralateral wall with measurement of 1.4 centimeter plus 1.2 centimeter, and prostate enlargement is there
Perfect.
with
Now, what
SEP
next do you want?
78 cc.
What next do you want?
So I want to go for cystoscopy, sir, to substantiate my finding.
So, are you planning a diagnostic cystoscopy, or you
Yes,
are
sir.
planning a
Diagnostic
PRBT?
cystoscopy. So diagnostic cystoscopy.
Is there any other investigation which will help us quantify this tumor better?
Sir, we can do CCT, whole abdomen and pelvis, which can tell about in detail about the lymph node involvement and anything if we are suspecting bladder tumor. But it won't differentiate from bladder mass and clots. So we have to do cystoscopy for it to differentiate between a clot and any tumor.
You don't want to do any testing for prostate, or like Dr. Maheshwari has asked, anything else which will, apart from CT scan?
Sir, MPMRI we can do, sir, multiparametric or biplanar MRI, in
Before
which
that, any
we can.
basic test? Now the hematuria is stopped. Urine is clear. Would you like to do some other test?
Sir, as hematuria stop, we can go for urine cytology, sir.
Okay, so then ask for it. You say, no, said when the urine, if the whenever there is no hematuria, I like to do in
Yes,
between
sir.
hematuria, I like to do cytology.
Yes, sir. Urine cytology.
And the for the prostate, you want to do something, or you just want to forget about that?
Sir, first I would like to have this MPMRI. It will tell us if any, it will rule out any malignancy. If it is there, then according to grades, sir.
Mhm.
To understand, you want MP-MRI of prostate?
Um, yes, sir, to rule out any malignancy and have a
But are you
grade high
suspecting
rates.
malignancy?
I'm not suspecting, sir.
Then why are you doing so? Would you want to do would it be done in every patient? What is the protocol?
No. So you are diverting the case from bladder tumor to prostate cancer. This is what you're trying to tell us.
Ganesh
Sir, I
bhai,
want to stick to
Ganesh bhai, can you just guide them how to
cystoscopy.
go about?
सर थोड़ा सा प्रॉब्लम है, मतलब जस्ट ज्वाइन, तो मुझे थोड़ा मतलब पता नहीं है कि क्या डिस्कस हुआ है, तो आई एम लिसनिंग लिटिल बिट टू गेट गेज एवरीथिंग.
Give an overview to Dr. Ganesh
नहीं
Bakshi.
नहीं, मतलब डोंट गिव एन ओवरव्यू. ओनली थिंग इज इफ द प्रोस्टेट एग्जामिनेशन वाज नॉर्मल ड्यूरिंग योर केस
अल्ट्रा
roughly, and abhi tak we have reached the imaging investigations, so I guess you must have done some blood investigations. So with that in mind, and maybe you might have done urine routine microscopy and possibly urine cytology. So with that in mind, this is a huge prostate, so depending on your PSA agar hai to you will have to think.
So that is what Gaurang sir just asked, that there is no hematuria. Would you want to do anything else? He was expecting you to say urine cytology.
Yes, sir.
Only thing is, matlab, somebody can justify saying ki patient is above 60 or 65 years of age, I would like to send a PSA.
No, PSA
PSA is normal. PSA is
is
normal.
sent and it is 2.9 or something.
हाँ, तो
सर,
I don't think
इसमें
then
बड़ा
इतने बड़े,
सिंप्लीफाइड है कि
हाँ,
सोनोग्राफी में तुम्हारे पास क्वाज लीजन है ब्लैडर में.
Correct.
ब्लैडर में तुम्हारे पास सोनोग्राफी में लीजन है, और वो दैट इज द प्राइमरी कॉज फॉर हिमेचुरिया. तुम्हारे पास आंसर है हिमेचुरिया का.
Yes,
I
देन
you
don't
are
व्हाई
need
यू
to
हैव टू
diverting.
waste
गो
time.
फॉर why you are going for MPMRI, why you are going for diverting
Absolutely.
yourself. वो गाड़ी चल रही है, उसको चलने दो ना. जब
Absolutely. He
बात
said
बात अगर वो
MPMRI,
तुम
and that's
वो
where.
एग्जैक्टली सिटी उसका नेक्स्ट आंसर शुड बी कॉन्ट्रास्ट ट्रिपल फेस सिटी स्कैन होना चाहिए.
वो शुरू से प्रोस्टेट के पीछे पड़ा हो.
सर इन बिटवीन प्रोस्टेट की मैलिग्नेंसी निकले तो निकलेंगे आगे चल के, ऐसा नहीं नहीं ऐसा नहीं है, लेकिन आज के घड़ी
उसका
में तो
मतलब मालूम
तुम्हारे हाथ में
है।
आंसर है ना।
या आई थिंक गीते सर सही कह रहे हैं.
Yes, sir.
So let's go with that.
So Atul, just let's summarize again. Unless
Yes,
the
sir.
PSA is elevated beyond 4 or you have a clinical suspicion, don't go in the line of MP-MRI prostate.
Yes.
Because here we can see a proper lesion, a 1.5 centimeter lesion, which is the source of bleeding and probably symptoms.
And you have
Yes.
a normal DRE, normal PSA. So I don't know why you should think about MP MRI prostate.
I think let us forget the MPMRI. तुम आगे जाओ, I think.
Yes, sir.
So patient
Sir,
presented with
CC.
hematuria, right?
Yes, sir.
So there is a 20-day history of hematuria, painless total with clots.
Okay, ठीक है. So आगे क्या करोगे?
Sir, urine cytology report. Sir.
Yeah.
ठीक है,
Sure,
but
cytology
one
report.
question, मतलब how is urine cytology going to influence मतलब your decision right now? Sending for it is fine, मतलब.
Yes, sir. So it won't affect the decision, but I would like to confirm.
So समझो यूरिन साइटोलॉजी का अभी नहीं, बाद में क्या डिसीजन अफेक्ट हो सकता है ये बताओ. Theoretically, your bladder tumor size is here written 1.4 by 1.2 centimeter. So यूरिन साइटोलॉजी किया अभी,
Yes, sir.
समझो पॉजिटिव आ गया.
Yes, sir.
One thing is, when does the urine cytology come positive? क्विक आंसर दो,
सर
टाइम वेस्ट मत करो.
सर अगर जैसे पेरिस रिपोर्टिंग सिस्टम के अकॉर्डिंगली अगर एटिपिकल सेल्स ज्यादा रहते तो
अरे
हम
यार, पेरिस का
3
1
में
to
डिवाइड.
6 नहीं पूछ रहा हूँ मैं. इट कम्स पॉजिटिव इन हाई ग्रेड यूरोथेलियल अप टू 86
यस
to
सर.
90%.
यस
Okay,
यस.
and up to 14 to 16% in low grade urothelial CS. Okay, so that is important. Paris का 1 2 3 4 6 you should know, but then
यस
that is some examiner can ask you क्या है Paris system ऐसा. But now,
यस.
what is the whole logic like? For this small tumor, 14 by 12 millimeter, what is the logic of urine cytology?
सर अगर हाई ग्रेड यूरोथेलियल कार्सिनोमा सेल्स मिलते हैं देन इट विल मोर meaning radical approach we have to use, like radical cystectomy we have
So,
to do
roughly
in
speaking,
high
it is
grade.
like this that urine cytology positive, we go on the 86 to 90% that there is a possibility of a high grade
High
urothelial.
grade tumor. Yes.
If I do this TURBT and find a low grade urothelial tumor, so the possibility of urine cytology usually कम रहती है. So I might pay extra attention to finding, either tumors elsewhere in the bladder which I have missed, or I will screen the upper tract very properly, maybe review the CT scan, CT view again with a good radiologist to see if I have missed any upper tract problems.
Yes, sir.
From where this high grade urine cytology is dropping down. बस ये
Yes, sir.
it aids in diagnosis. मतलब it is considered that urine cytology positive means urothelial carcinomas are seen. And तुमने
Yes, sir.
ऐसे loosely urine cytology बोला because I said that urine cytology. So very very properly it is sent on 3 consecutive days ऐसा.
Yes, sir.
Okay, so let's go ahead. What do you want to do?
Sir, next I would
Harshu,
like to
we have
see.
1 second. Harshu, we have done cytology.
Yes, sir.
Just show them, na.
दिखाओ भाई.
Sir, we have done
Atypical.
cytology on 3 days, and all 3 days it was atypical urothelial cells with Paris category 3.
So technically, मतलब in broad words, we can say it is negative.
Negative.
Yes, sir.
Okay,
So
so
it
then
is kind of
now
in line with what I said.
when he was saying Paris, let us ask him,
No.
what is that?
तो ज्यादा पैथो के एग्जाम में पूछते हो.
No,
Sir, this Paris system reporting is, sir, about if there is increased nucleocytoplasmic ratio, if it is, meaning will have 0.5 as a limit. If it is more, then we'll check for presence of hyperchromasia, coarse chromatin or irregular chromatin rim. If at least 2 features are present and high nucleocytoplasmic ratio is there, then we again quantify. If quantity is like less than 5 to 10 cells, then it will be suspicious for high grade urothelial cancer. And if they are many, meaning more than 10, then it will be categorized as high grade urothelial cancer. If among hyperchromasia and coarse chromatin and irregular chromatin rim, if any one feature is present, we will categorize as atypical urothelial cell. If it all are negative, then we'll categorize it negative for high grade urothelial cancer. So this is Paris version 2.2.
Fine. So this is what I wanted all the students to know. Fine.
Yes.
So this is a situation. Now what you want to do?
Sir, as this is showing atypical urothelial cells, so meaning it is not meaning it's not diagnostic. So we will proceed with more definitive approach like cystoscopy, or in which we can actually see the tumors. Diagnostic cystoscopy, I would like.
So you want to do CT scan now, or you want to do CT scan later, or you don't want to do CT scan?
Sir, CT at present I don't want to do, sir. First, I will go for diagnostic cystoscopy. Accordingly, I will do CCT.
Gite sir. Ganesh, what is the latest trend now? We should go first for the CT scan, or we can wait?
Sir, safe answer is hematuria hai, so we can always
अरे वाला
justify for a CT IVU मतलब.
सिटी स्कैन बोले वाला अच्छा रहेगा सर.
वो इजी रहता है बोलना सर,
नहीं,
जस्टिफाई करना भी बहुत इजी रहता है सर.
सिटी स्कैन नहीं करेंगे तो भी डिफेंड कर सकते हैं ये स्टेज में, लेकिन
हाँ, बिकॉज छोटा ट्यूमर है.
हाँ छोटा ट्यूमर है.
बट हिमेट्यूरिया दिखा तो बोलने को बहुत आसान पड़ता है सर कि आई विल डू अ सीटी स्कैन.
एग्जैक्टली.
So please, all the students understand, it is always better to say, I will like to do CT scan in most of the cases.
हिमेट्यूरिया है तो यू कैन सेफली से एंड जस्टिफाई.
Yeah.
हिमेट्यूरिया नहीं है एंड स्मॉल ट्यूमर है तो जैसे गीते सर ने बोला वैसे बोल सकते हैं. एंड हिमेट्यूरिया नहीं है एंड बाय चांस बड़ा ट्यूमर है 3 सेंटीमीटर के ऊपर, तो अगेन वी कैन से कि द ट्यूमर इज बिग 3 सेंटीमीटर प्लस, सो वी वुड आस्क फॉर अ सीटी बिफोर.
And if the cytology is positive, then again we can say that we like to do, because to rule out the upper tract, correct?
कर सकते.
Yes, sir.
No problem.
Fine. Okay.
So again,
Harshiv, show them the CT scan.
थोड़ा और इमेज है क्या ब्लैडर का स्पेसिफिक?
Harshiv, पूरा दिखा दे. Just show them all the films and then concentrate on this.
Yes, sir. Sir, I'll have to share another photo with it.
आ रहा है क्या दूसरा फोटो? अगर ग्रॉस प्रॉब्लम हो रहा है तो रिपोर्ट बता दो. ऐसे कुछ सीटी स्कैन रीडिंग इज आई थिंक वी हैव डिस्कस्ड इट सो मेनी टाइम्स विद स्टूडेंट्स.
Sir, in the CT report, there is mild stranding of the perinephric fat planes. Urinary bladder is partially distended. Focal areas of wall thickening on the background of mild diffuse thickened wall noted in the bladder. Few enhancing lesions anchored to the right lateral, posterior, and left anterolateral bladder walls are seen, which appear as filling defects in the delayed phase. The largest of these lesions, which is anchored to the posterior bladder wall, measures 2 cross 1 centimeters in the axial plane. There is no obvious extraluminal spread noted. There is perivesical fat is maintained, and no obvious urethral calculus is seen. There are multiple renal cysts, Bosniak 1 grade. There is mesenteric paniculitis and prostatomegaly with median lobe indentation. Seminal vesicles are normal.
So sonography was showing only one small lesion, and now you can see that there are multiple lesions. So many times, unless and until you get sonography done by a particular sonologist whom you know very well. And if you are standing there and getting it done, I think it is very safe always to look for CT scan.
Yes.
So Ekansh, this is us now all investigations and this is history. What do you like to do? Atul, you can answer now. I think Ekansh
Yes,
has
sir.
le-
Sir, I would like to do cystoscopy, sir. Again, I will tell. Diagnostic cystoscopy, I would like to do, sir. Because I want to confirm this finding by diagnostic cystoscopy.
डायग्नोस्टिक सिर्फ बोलना यहाँ थोड़ा सा गलत रहेगा, क्योंकि रेडियोलॉजिकल डायग्नोसिस आपके हाथ में है और देयर आर मल्टीपल ट्यूमर, एंड इफ यू आर गोइंग इन देन योर प्लान शुड बी एसोसिएटेड ट्यूआरबिटी आल्सो. तो सिस्टोस्कोपी एंड ट्यूआरबिटी करना है, इतना अंदर जाके देख के वापस आने वाले है क्या?
Yes, sir.
तो मुझे लगता है कि
Sir,
इट शुड बी सिस्टोस्कोपी एंड ट्यूआरबिटी. इट मे बी कंप्लीट इनकम्प्लीट, जो भी जैसा अंदर फाइंडिंग निकलेगा वो हिसाब से रहेगा.
yes, sir.
प्लस माइनस एज पर द फाइंडिंग ऑफ बायोप्सी आल्सो, अगर तुमको कोई इंडिकेटिव लगा तो.
So there is
Yes, sir.
practically very less role for diagnostic cystoscopy at this time in such a patient. And now we know that there are multiple tumors. So we would not want to take the patient twice, two anesthesia, two procedures. So obviously we go in with the preparation to remove the tumor.
Yes, sir. Sir, then we can, under anesthesia, we can do as a part of TRBT procedure, we can do diagnostic cystoscopy and bimanual examination as well as rectal examination accordingly. Sir, under anesthesia, it will be better. We can palpate the tumor if it is in perivesical structures also.
So, Atul, what you are saying is right. But, in today's time, with such good CT scan facilities available, what is the possibility of this tumor being extravesical or being felt on bimanual examination? So, bimanual examination is a very interesting thing, something which you should mention in exam, but also be ready to criticize it.
Yes, sir.
If you don't mention it, examiners will ask about it. So better to say, so when you are describing the procedure, say under XYZ anesthesia, under antibiotic cover, I will do bimanual examination followed by diagnostic cystoscopy, map the tumor well, and proceed
Yes,
with resection. And it
yes,
will be better that while describing resection, you talk of the energy source and what all you will do. So in one sentence, finish off everything.
yes, sir.
बोलिए क्या करना चाहते हैं?
Sir, first of all, I will anesthesia I'll use is under general anesthesia and with complete muscle relaxation and under proper antibiotic coverage and energy source as bipolar or laser. Both have less chances of obturator reserve and with moderate amount of bladder filling and yes,
Okay. Ganesh, anything else you want to ask?
what is the role of MRI in this case?
sir, MRI can differentiate blood clot as versus the bladder tumors. Any meaning it will differentiate any clot with the
देखो, जब एग्जामिनर पूछ रहा है स्पेसिफिकली, तो उनके दिमाग में कुछ तो भी एमआरआई का इसमें रोल है.
yes,
हाँ, अगर क्या रोल है, these are all are radiologically superficial tumor. पर फॉर
yes,
सुपरफिशियल ट्यूमर विच इन्वेस्टिगेशन सीटी एंड एमआरआई कंपेयर किया फॉर एग्जांपल. सो करंट गाइडलाइन के हिसाब से क्या अच्छा है?
sir,
सीटी
for
अच्छी है
lymph
कि
node
एमआरआई
CT
अच्छा
is
है?
better and for proper lesion delineation, MRI is better, sir.
Sir is asking about, do you know about Wired? Sir is giving indirect hint to you, Gaurang sir.
Yes, yes, sir.
Yeah, sir is asking that only.
Sir, vesicle imaging and reporting and data systems. Wireless.
So do you think it has got any role on in this case?
So the lesion is more than 1.5 centimeters, so it has roles, sir, definitely.
Okay,
The
go ahead.
maximum diameter is 2 centimeters, and that's why in axial plane. So wireless can help, sir. Sir, but still we need a pathological diagnosis after that. So I
Actually,
would go for TRB.
just show them what we did then.
Post TURBT, histopathological samples were sent. One was deep tissue bladder biopsy and another was the tumor. In the deep tissue biopsy, it showed features of high-grade urothelial carcinoma and infiltration into the deep muscle. In the tumor, it showed high-grade urothelial carcinoma with lamina propria invasion.
Sir, as this is a high-grade urothelial carcinoma, I would go for re-TURBT, sir, again.
Atul, I am sorry to
After
say,
6
but
weeks.
you need to really revise the topic once again. We are really going haywire. We have already documented deep muscle positive in this patient.
Why do you need re-TURBT?
When it is already diagnosed muscle invasive, how will re-TURBT help you? Can you see here deep muscle positive?
Sir, 2 specimen not given, sir, here. 2.
ये दिख रहा है ना 2 specimen. First is deep bio tissue bladder
Okay,
and
okay,
second
okay,
is
sir.
bladder
My
tumor.
screen is not visible properly. Sorry, sir. Yes, sir. I will go for radical cystectomy, sir. Sorry.
Directly. So what about the metastatic lung lesion?
Sir, to rule out METs, we have to do PET CT, sir.
एग्जाम
And
में ये
chest
कभी
X-ray.
गलती मत करना कमिट करने का.
Chest
I'll do a
X-ray.
radical cystectomy. The operation itself you said in a mail was wrong.
Yes.
We have to do or you will do?
नहीं भाई, थोड़ा सोच के बोलना है.
Yes, sir. Yes.
गड़बड़ अर्जेंसी नहीं है. कोई भी क्वेश्चन पूछना, जस्ट गिव एटलीस्ट 10 सेकंड टू योर सेल्फ, थिंक, articulate the answer in your mind and then tell.
Okay, sir.
बट
Okay.
बोल के बोलना कोई जरूरी नहीं है ना. एग्जामिनर ने
Yes,
पूछ
sir.
लिया तो इमीडिएटली बोल दिया तो ये पास करने वाले, ने तो नहीं करने वाले क्या.
Okay, बोलो अभी क्या करोगे?
Sir, first I want to, as this is a high-grade urothelial carcinoma, so I would like to rule out any distant mets are there or not. So I would like to do PET CT scan, sir.
Which type of PET?
PSA
Sir, FDG PET I would like to.
Okay. Patient
Okay.
diabetic.
Patient is non-diabetic.
Okay, no problem.
HbA1c is 5.4, sir.
Okay. समझो पेशेंट डायबिटिक है तो क्या एफडीजी पेट में क्या केयर लेनी पड़ती है?
Sir, because this is a meaning glucose dependent procedure, so we have to give patient some diet to decrease the hypoglycemic episodes.
If patient is diabetic, you have to see that on the morning of the FDG PET scan, the sugars are in quite control.
Yes,
That's
sir.
it. You
Yes.
don't have to give any medicine to create hypoglycemic episodes.
Mhm.
I don't know, मतलब तुम थोड़ा confused हो या डरे हुए हो, but exam में थोड़ा सा गीते सर बोले वैसे confidently answer करना.
Okay, sir.
Okay, so metastatic workup report है कुछ?
तेरे को
No, sir,
अनम्यूट
we
कर दो
have
और कोई आंसर देता नहीं है, तेरे को पूछूंगा मैं. ठीक है, in between. Okay.
so the patient is just yet to come for the follow-up. So this is the last report that we have as of now.
So consider that the metastatic workup is normal. आगे क्या करना है आपको?
So metastatic workup, you can say only PET scan, or you can say something else also.
हाँ, CT chest बोल सकते हैं with maybe मतलब bone mets is rare, but you can just cover up with alkaline phosphatase.
yes, sir. Bone scan we can tell, sir. Bone
No,
scintigraphy.
bone scan don't say directly.
Bone scan करने की जरूरत नहीं है bladder में.
Yes.
For bladder tumor, better than FDG is to get a CT of abdomen and chest done.
Yes.
And bone scan only if alkaline phosphatase is high or if patient has some bony pains.
Yes.
Otherwise, bone scan is also not needed.
Yes, sir.
It's not prostate cancer, इसलिए पंकज सर ऐसा बोल रहे सर.
Okay, sir.
Okay. So now we have done the CT chest. It is normal.
Yes, sir.
Alkaline phosphate is also normal. Everything is fine.
Yes, sir.
Now what you want to do?
Sir, as this is a high risk tumor, sir, because patient is also having this tobacco risk factor, will see the age is more than 70 and multiple papillary tumors are there. So we should give, sir, a single installation of chemotherapy for this patient. Meaning mitomycin C.
Atul, we have moved far away from there. We have already seen the histopathology report. Single installation कब देते हैं?
So within 24 hours we have to.
So histopathology report कितने दिन बाद आता है?
Minimum 3 days after.
So you are minimum 3 days after the procedure. So अब single installation की बात करके क्या फायदा है?
Yes, yes. Okay, then sir, we'll go for radical cystectomy.
So Atul, now
yes,
so go back. Now when you are doing TURBT, in this case,
yes.
you are not going to do diagnostic cystoscopy. You are going to do cystoscopy followed by TURBT, and you like to do the total TURBT if possible, correct?
Yes, sir.
And so now in this tumor, after finishing,
Yes,
will you like to put a mitomycin or you will withdraw?
sir, I would like
or
to.
you will like to do mitomycin?
Sir, I would like to give a single installation of mitomycin C, sir. It will decreases the chance of recurrence 12% by 12%.
Be happy. I understand what is going to happen.
That is exactly what I hope, that living experience from what.
So no, tell me. So tell me what are the, so let us say what are the indications of mitomycin and what are the contraindications?
Sir, if for first indication, I'll tell, sir. If we are suspecting low-grade tumors and the patient age is more and the risk factors are more, then like here, tobacco chewer, he is tobacco user, so it is a risk factor. So it will decrease the chances of recurrence afterward. And what about the contraindication is any bladder perforation is there or any UTI is there, active UTI is there, we should avoid using this
So tobacco chewing is the
intravesical.
indication. That is the indication of mitomycin C.
Atul,
Risk factor.
if there is an active UTI, will you do TURBT at that time?
No, sir.
Then why are you talking of active UTI?
Yes, sir.
And the decision, as Hiren sir is saying, the decision of mitomycin C, does it really depend on tobacco, smoking or such factors?
No, sir.
Then आप ही बोल रहे हो बेटा और आप ही उसको contradict कर रहे हो.
Sorry, sir.
So there is a small tumor 1.5 or 1.4 centimeter, or you are going inside for a TRP and you find some 2 or 3 growth inside. Will you like to put a mitomycin?
Sir, no
Suppose if
need
there is a
actually.
growth of 5 centimeter, sessile
Mhm.
growth, and after resection you feel that still some tumor is left behind. Will you like to put a mitomycin?
Did you attend last week's class or did you see the Saurabh told what are the indications of mitomycin C?
So it
Dr.
is
Saurabh.
ideally for solitary lesion if it is less than 3 centimeter and in completely resected tumor without any risk of perforation.
So any risk for muscle invasive? Any indication? This is muscle invasive tumor, no?
Yes, sir. No, sir.
Let me simplify this to you. You see, you need to
Yes, sir.
decide on table whether this
Mhm.
patient is likely to need intravesical BCG or not. Most of the indications of intravesical BCG, there you do not need to give mitomycin C.
Yes, sir.
So it is given for small, low-grade tumors where you
Yes,
are not going to give any intravesical immunotherapy like BCG.
yes, sir. Yes, sir.
So there mitomycin will help. In this patient, you had multiple tumors. Sorry.
Yeah. So you understand what Dr. Pankaj Maheshwari is trying to tell you?
Yes, sir.
First of all, like you have done a cytology.
Yes, sir.
Cytology is negative. Tumor size is small. It is not sessile, correct?
Yes,
Pedunculated.
yes, sir.
And it is not very small, more than 1.5 centimeter, less than 3.5 centimeter, pedunculated. Cytology is negative. When you go inside, you feel that yes, it is definitely not muscle invasive, and you have
Yes, sir.
resected the hole. There is no bleeding, no perforation. Okay, and these are the
Yes,
cases
sir.
where you like to do mitomycin therapy.
Yes, sir.
Otherwise, you will withhold. You will not like to do it. Correct?
Okay, sir.
So now in this case, will you like to do mitomycin?
No need, sir, in this case.
So let us ask Ganesh bhai. Now in such a case,
Sir. Yes, sir.
what you mean? So if there are more than 2, 3 masses, but they are all 1.5 to 2 centimeter, so after resection, one should put mitomycin or not. Collectively, they are more than 4 to 5 centimeter, but
But ऐसे
individually they are
कभी कभी
small.
क्या होता है collectively low grade भी रहते हैं.
हाँ,
So if they are easily resectable and you have a gut feeling that they are not invasive
right.
and you have not left any residual, then you can end up giving one mitomycin. It is not harmful.
Correct. So I think that should be the answer. That if there are
Yes, sir.
multiple, but your like his sir said that you feel that
Yes,
clinically
sir.
looking at that they are not high grade, because see when you see multiple TURBT,
Many times a good urologist will say काटते काटते कि भाई ये मुझे doubt है
हाँ,
muscle invasive का. Now that doubt
हम्म,
might transcript into a report saying muscle invasive or transcript into saying not muscle invasive. But when you have a gut feeling of a doubt of muscle invasive, don't give mitomycin because it is not indicated. There is one more
Yes, sir.
small cut practice मतलब कि sometimes if you don't give mitomycin, there's a paper which says in literature that if you just give a irrigation for 24 hours, sterile water, it almost acts like a single intravesical, mitomycin, immediate mitomycin.
And this temperature should be what? 46
नहीं
degree, 45
नहीं
degree or
सर
room
नॉर्मल
temperature?
नॉर्मल नॉर्मल वो
Normal.
हाइपोथर्मिक नहीं है, ये नॉर्मल है.
Okay. Okay.
This paper says that it is like just equal.
Oh, good.
So sometimes you can, कभी कभी ऐसा लगता है कि say TURBT के बाद I have created 2-3 micro perforations and I am not so comfortable giving a mitomycin. But the whole logic of giving that immediate intravesical post-op mitomycin is to prevent the shed cells from seeding into the raw area and other parts of the bladder, other mucosa. So the same effect can be got by this paper saying giving an irrigation for about 24 hours.
Yes.
Fine. Understood, Atul?
So ये
Yes,
थोड़ा सा
sir.
different है. I mean, this is a practical tip for everybody. Like we
Yeah.
can just use it. I have used it couple of times.
We
Sir,
should
if
also
we'll
use.
use a mitomycin C, it usually decreases the tumor cell seeding also. Even in high-grade tumor also, it will decrease the tumor seeding.
So it will decrease, no problem. But yeah,
Okay.
I
So,
don't think the debate is about that. Debate is about, I mean, anyway,
yeah. So,
this is a muscle.
Atul, how you prepare the mitomycin, how it is available, and what you will do?
Sir, sir, in recomposition, sir, vials are available. In that we have 40 mg.
So usually it is 10. So 4 vials
Sorry.
we take.
Yes, sir. For 4 vials we have to take, and we have to dilute and in normal saline and reconstitute it, and then we'll keep it for
How
30
much?
minutes.
How much? How much fluid?
100 ml saline.
100 or 50? Ganesh? Swastik, can you just tell them?
Sir, 40 cc of mitomycin C in 50 cc of normal saline, sir. And we can also increase the concentration by decreasing the volume of saline used to 25 cc and double the concentration of mitomycin C. That also can increase the uptake.
And it should be done within 6 months.
Yes,
6 hours. Or
6 hours of the TURBT, sir. Yes, sir.
And how will you put it?
Sir, with a catheter inside, sir, we will just after the constitution of mitomycin C, sir, we will just we will fill it with a asepto syringe, and by the force of gravity only will let it go inside, sir, in the bladder. Will not push it.
And then you clamp it.
And then clamp it and keep it for 1 hour and then remove, sir. 60 minutes.
Okay.
Yes, sir.
Fine.
The temperature
Understood?
is 42 degree.
42 degree hypothermic we can do, yes.
So Atul,
Yes.
what happened? I was doing this case, but the prostate was very big.
Yes, sir.
So I plan to do TURP. Is it okay?
Sir, it will likely cause this tumor cell to embed in the prostate, and they can cause meaning implantation, tumor implantation will be there. So we should avoid using doing TURP in this case.
Acha, in which book it is given? Or have you read any paper regarding this?
Sir, I have
Swastik?
read somewhere.
Swastik, the I think is, can you do TURP and TURBT together?
Sir, we can do TURP and TURBT together, sir.
Yeah. So Ganesh, please enlighten them.
So there is ample literature which says that doing together does not increase the risk of prostatic fossa implantation. And it is safe to do both the procedure wherever indicated. Now, if the prostate is very large and the tumor is positioned in a way that the large IPP or median lobe is coming in the way of your resection, then probably it would be worthwhile doing resection and bladder tumor resection both together. So Atul, I don't think there is any literature which says that there is implantation. It is very safe to do both together.
Okay, sir.
So Atul, I did actually TRP on him, and then I did because the mass was supposed to be very small, and patients,
Yes,
if you see urochromatrin, everything was quite affected, and he was
yes.
quite worried about the prostate. So now
Mm-hmm.
I've done it, and I wanted to put mitomycin. Is it okay with the TRP?
Sir, my tomycin C will cause meaning it cause irritation. So patient might complain of dysuria for that. We can give, sir, actually.
You can give, yeah?
Yes,
There is no definite contraindication.
yes,
Unless and until again, if you feel that you have gone resected too much and you have opened up the channels,
yes,
capsule has been opened up, there is a bleeding, then you don't want to
yes,
do.
yes.
Yes, Parth, you want to say something? You can unmute and you
Yes,
can
Raja
tell us.
Center. Sir, in Campbell, it mentions regarding the TURP and TURBT. It says the resection of high-grade bladder tumor should not be performed coincident to TURP to avoid the tumor seeding and possible intravasation of tumor cells likely to metastasize, sir.
Okay, in the new campaign?
In the 12th edition, sir. The previous one.
Okay. But in the
Yes, sir.
newer edition, it is given or it is not given now?
So that I'll have to check, sir.
no. Current literature wise also, both TURP and TURBT can be done simultaneously.
हाँ कैसे मैं बोलता हूँ ना कि patient had radical cystectomy. I
Until,
presented with this.
hello, who is talking in between? So TURP and TURBT both can be done simultaneously. Only issue here is time. With both very large prostate and very big tumor, then resection time is important. ब्लीडिंग का चांस, अनास्थेसिया, ये सब चीजें अगर सुटेबल है सब कुछ, समझो ट्यूमर लेस देन 3 सेंटीमीटर है, प्रोस्टेट भी 20 40 50 ग्राम का है, तो दोनों एक साथ कर सकते हैं. एम्पल लिटरेचर अवेलेबल है. कैम्बेल में अभी के है कि नहीं है ये मुझे भी पता नहीं है, देखना पड़ेगा, लेकिन ऐसा लिटरेचर अगर सर्च किया तो दोनों एक साथ कर सकते.
I think in exam it is, if the examiner asks, I think it is safe to say, okay, yes, if required, we can do both the things together.
Yes.
So,
Okay.
Parth, I have just put you a recent article which says that both are very safe and there is ample literature to support this.
Correct.
Okay, sir.
You see, the moment
Yes,
you give reference of Campbell, it puts everybody on back foot. But I would definitely recheck that to the best of my understanding, and whatever I have read, I think both can be done together.
If it is really given, he himself should search it and put on the group, so
Yes.
that everyone should know.
Yeah.
Yes, sir. I'm just putting sir on the group, sir.
Yes, yes. Fine. Okay, so Parth, you are already finished your exam or you are at exam going?
Yes, sir. Finished, sir.
Okay, okay. Fine.
Yes, sir.
Okay, so Atul, now
Yes.
how you will go ahead? What you will talk to the patient? What you are going to explain?
Sir,
You have done
sir,
everything.
regard
You have finished off your investigations. You have done the metastatic workup and all the examination. You know, all investigations. They are okay. There is no comorbidity, and he's fine.
sir, we would like to counsel the patient for radical cystectomy, and
So before that, how will you put him? How will you put forward to him that he has got a cancer?
sir, we have to explain him about the prognosis that he has a malignancy in the bladder, and After first TRBT only, we have on during pathology report we found that it's high grade tumor. So uh, meaning future prognosis we have to explain.
So how will you explain him? What you will tell him? See, there are 5 questions the, the patient is going to ask him.
Yes.
Correct. Once you tell him that you have got a cancer, many
Yes.
of them will start crying
Mm-hmm.
because they think that now cancer is cancelled. They are gone. So now
Yes, sir.
how you are going
So
to
first
explain?
we'll counsel the patient that this malignancy is treatable and 5 year meaning survival rate is good in these cases as this is not metastasized to distant organs. So it is localized disease in the bladder only it is there. So we will explain to the patient like with proper follow-up and treatment he will be good like that. We have to explain his prognosis.
No, the patient is asking you, doctor, you tell me how many years I'm going to live. Second thing, he will say, okay, what you are planning to do? Are you going to do only surgery? You're going to give me light also. You're going to give me medicines also, chemotherapy. What will happen to my hair? What will happen to my skin? What will happen?
Sir, we have to explain about the
So you tell us
chemotherapy and
now.
radiotherapy options.
So you tell us in detail what you're going to plan now in this patient. There must be something in your mind, na?
Yes, sir. Sir,
So
about
tell me what you want to
radiotherapy,
do.
we will explain the
No,
patient about the
yeah.
number of cycle and fractions, how many cycles it will be needed, and what will be the side effect. Like he may have bowel
No, no. Why
discomforts
you're
and
going directly to
rashes.
radiation? Listen, Baba, how
Yes, sir.
how you're going to treat this patient? Tell me. And so that is how you're going to explain to the patient. First of all, with empathy and sympathy, you will say that yes, you have got some disease. This is like you've got a malignancy, but we are lucky that it is still in the bladder, but it is muscle invasive. So we'll have
Yes,
to
sir.
remove your this organ. So you'll explain him. So tell us what are the things you're going to remove.
Sir, we will, if radical hysterectomy and pelvic lymph node dissection we have to do for this patient. If
Along
patient
with
is not
and
willing
along with
for
that, what
or
you'll do?
unfit,
Along with that, what you'll do? Say the complete treatment, na?
s- sir, after meaning if patient is refusing, then
Arey
BCG installation
Baba,
therapy.
you are going to remove the bladder.
Yes,
Then
sir.
what will happen to urine?
Yes, sir. That diversion we have to do, sir. Meaning neobladder or ileal conduit, we have to give options like that.
You will give option or you will decide.
Sir, we will let patient decide. Sir.
And
If patient is not willing, then we have.
but
If
I'm
patient is refusing for radical cystectomy, then other
no, no.
option we have to select bladder conservation
We
therapy.
are
Like that.
not going to that stage. At present, I
Yes.
am asking you, what is your plan of action?
So my plan
Oh,
of action will be radical cystectomy and pelvic lymph node dissection. We'll explain to the patient, and uh, as this CT chest and abdominal is normal, no need of neoadjuvant chemotherapy. We'll directly do radical cystectomy and pelvic lymph node dissection. No need of radiation also for this case.
so again, Baba, why you saying only radical cystectomy? In
Yes,
in
sir. Meaning,
in operation
uh,
theater, what you are going to write down?
mm, sir, meaning radical cystectomy and ileal conduit or neobladder, orthotopic neobladder.
With a diversion. Just say at least in
Yes,
the
sir.
exam, say,
Diversion.
"Look, I'd like to do radical
Yes,
cystectomy with a diversion."
yes,
What
sir.
type of diversion you'll do, that we'll ask you later.
Yes.
Okay. So what is the role of neoadjuvant chemotherapy? As you are saying that there is no role. Then where you will when you will give neoadjuvant chemotherapy?
Sir, if CT chest and pelvis is showing clinically, if it is more than T2 lesion is there, and meaning T4A like and node 0, then we have to give neoadjuvant chemotherapy. If it is node also positive, then chemo radiation both we have to do. If T4B lesion is there clinically, then palliative cystectomy we have to do. So like that we have to do.
I think
Atul,
Ganesh bhai.
I would suggest you read the AUA and the Canadian Urology Association guidelines of muscle invasive bladder cancer once.
Sir, I am telling according to EAU, sir.
I'm pretty sure it may not have been written in EAU like this, but still reconfirm this.
Ganesh bhai,
Sir,
can you just throw some light on this?
Sir, Ganesh sir is busy for some time.
Okay, okay.
Hmm.
Because there is definite, if there is a metastasis, already metastasis, then there is no role of radical cystectomy.
yes, sir.
So you see, the principle of neoadjuvant is that you want to take care of the micrometastases that are there. And
Yes.
it is well proven that neoadjuvant chemotherapy helps when done prior to radical cystectomy. And it is part of protocol by at least AUA and CAU guidelines. EAU I'll also check.
And I think Brijesh or Swastik, can you just tell us, you read it very recently, that what is the overall survival rate if you give neoadjuvant chemotherapy?
Sir, it has a survival benefit of around 5% over upfront upfront radical cystectomy and then followed by adjuvant chemotherapy. Neoadjuvant chemotherapy has a 5% added survival benefit over this. And it has also three advantages that firstly, it can help us treating the micrometastasis. It can also give us the knowledge about the response of the tumor to the chemotherapy. And third, sir, many times patients after this radical surgery are not fit for a longer time for chemotherapy. So neoadjuvant chemotherapy has an advantage in that also, that we have given the chemotherapy and tackled the micrometastasis earlier. Downside is that if the tumors are not not chemosensitive. Hello, sir.
Yeah.
If the tumor is
Tell
not
us.
chemosensitive, so we will lose time before we perform the surgery, sir.
Correct. So if you think that after chemotherapy, if the patient is will not be fit for a longer period of time for a radical cystectomy, it is not worth giving neoadjuvant chemotherapy and directly go for a upfront radical cystectomy with a diversion.
Yes.
So suppose if you want to go, and within how much time you like to do radical cystectomy after biopsy, when you after doing TURBT? What is the golden period?
Sir, 6 months.
6 months. So by that time, the metastasis will take place. 3 months.
3 months, sir.
Okay. 3 months.
Yeah, within 3 months, you must go ahead with the radical cystectomy. Otherwise, the chances of metastasis are very high. Okay. So what type of diversion you like to do?
Sir, I would like to go for orthotopic neobladder because it will increase have a good quality of life for the patients.
So first of all, before that, let us talk about the lymph node dissection. So what type of lymph nodes? Which are the group of lymph nodes you will remove it?
Sir, hope lymph node, sir, hypogastric, obturator, pelvic, and ep, epigastric, externally external.
So what is the extended and extra extended means lymph node dissection? What is the advantage and disadvantage? And when you will not do or do?
Sir, in lymph node dissection, sir, extended lymph node dissection won't meaning not have any added advantage over this because here lymph nodes are not involved as per the CT.
Okay, so if it is involved, up to what level you will go? So what it is showing that external this thing
Sir, we'll
external
limit
iliac
ourselves
vest
to bilateral pelvic lymph node dissections.
up to what level? Extended means up to what level?
So meaning internal iliac, external iliac, obturator, and pre-sacral lymph node. That's all. Additional drainage site meaning common iliac, para-aortic, intra-aortic cable also. We have to check intraop and then we can do on the basis of intraop findings. Sir. Standard lymph node dissection will include, sir, only removal of bilateral external, bilateral internal, and obturator lymph nodes. Sir.
Okay. So now what are the different types of normal which we have seen? Are the conduit or diversions?
Sir, ileal conduit we have seen at our centers. Sir.
What else? What are the other options?
Sir, other options are mitrophin of like appendix in which we can do CIC, and other things are like orthotopic neobladder, sir, and uh, stomach and colon also we can use, but they have ileum is best as a conduit because less complication and electrolyte imbalance will also be less.
Mm. What else? Suppose a patient is now 120 kilo. So tell me which is better, whether to do robotic or whether to do open. And you are not able to, there is too much of fat. You are not able to bring out the conduit. And there is a mass, there was a mass very near to the prostate. You cannot do neo bladder also. So what will do?
Sir, robotic will be better, sir, for that case, if it is morbidly obese patient.
Okay. And then what type of conduit means diversion you will do?
Sir, ileal conduit will be better in this
No, but
case.
it is not coming out because the mesentery is so thick and the abdominal fat itself is about, let's say, almost 5 to 6 inches.
Mm-hmm.
So if you, even if you with a difficulty, great difficulty you bring out, it will again slip back, na? It will go inside.
Yes, sir.
So what other option you got?
So mitrophenol we can do, sir, in this case, as appendix has some length and it can
You
come
think that
out with.
if the ileum cannot come out, how the appendix will come out?
Mm. Sorry, sir.
Where else you can put it?
Mm.
You know only two options.
Yes, sir.
Swastik.
Sir, we can do a ureterosigmoidostomy, sir. Anastomosis of ureter ends to the sigmoid cell.
Huh. So that is the third option.
Yes, we can use ileal conduit as an incontinent diversion. We can have a continent diversion. We can have orthotopic neobladder, and we can have ureterosigmoidostomy as an option, sir.
Okay. So now you've done the ileal conduit in this patient. How will you follow up in the ward? What are the things, what are the parameters you will look? Atul,
Sir, meaning post-operatively or sir,
yeah,
overall?
post-operatively. post-operatively?
Sir, post-operatively, meaning this
So what are
patient
the
will have to
orders you
be,
will put it on the paper?
sir, boil preparation and um,
Pre-operatively
liquid diet
already
for,
open. You already done the surgery.
okay,
Now,
okay.
what are the post-op orders you'll put, and how will you follow up this patient in the ward?
Sir, the color of stoma we have to check, sir. That ureterostomy we have done. That color, if color change is there, sister should inform directly to the uh, uh, doctor. And if a patient is having any disorientation, electrolyte abnormalities, we can suspect, and we can uh, tell that patient sisters that we can directly call us whenever he is having any disorientation or any clinically abnormalities. Vitals we have to monitor properly, sir.
They very systematical. What are the things you will look for the vitals? Why vitals are important?
Because patient will end up in hypovolemia after
One
this.
is hypovolemia. Second,
Second, uh, um,
there is a blood
is
loss, there is tachycardia.
discoloration.
There is anemia, there may be tachycardia. Correct?
Yes,
Then
yes.
you've done a long.
Discoloration of the ureterostomy side. We have ileal conduit. We have to know that stoma. We have to see if it is ischemic. Then we need urgent intervention.
Now the patient developed he had a 92 centimeter abdominal girth,
Mhm.
and it has now become 95. So what are the causes?
Sir, it can be urine leak also can be there.
See,
So
to
we have
urine
to
leak,
check
what
the
is the first?
drain.
Again, what is the most common
Drain.
thing?
Uh, Increasing the abdominal girth, sir. It can be due to bleeding or uh,
What is the most
hematoma
common?
inside.
What is the most common?
Alias, sir.
No,
Obstruction.
first, अरे भाई, first it's alias, na? It can
Yes.
be, it is secondary to paralytic alias.
Yes.
Second cause,
Second cause can be due to this sir, urine leak among what we have done anastomosis from ileum to ureters. There, any leak can be there, and um, then hematoma can be there, sir, if bleeding is there inside.
so obstruction can never be there.
Obstruction first, sir, will keep ileus meaning alias meaning like paralytic alias as well as physiology.
So it can be paralytic alias or it can be
Post
obstruction.
anesthetic
Then
obstruction.
urinary leak
Yes, sir.
and sometime bleeding, but that you will usually see into the drain unless
Yes,
and
sir.
it is blocked.
Yes, sir.
Okay, so what you will do then?
Sir, we'll go for ultrasound to look for
So
any.
every distension next post-op day, if it has increased, immediately you do the sonography.
No, sir, not for every case, but this case we will have high suspicion because we will lose time if the patient is having hematoma or mm, then we should not wait. I would personally go for this ultrasound
I don't think so. And see, clinically, you have to
because
examine. You have to
yes,
see
sir.
if the patient is not very uncomfortable, if the hemoglobin has not decreased, if the drain is draining. Let's say there are 200 cc of drain in the urine. I mean, the drain is there. Then, if you are suspecting, just see, empty it and see again it is coming or not. If it is coming, that means it is draining well. You can
Yes,
send that fluid for the, if you are suspecting leak or something, you send it for the uric. Yeah, this thing,
yes,
creatinine. You see the serum creatinine your urine creatinine and the creatinine, and you compare whether there is
Yes.
a urinary leak or not. Correct?
Mhm.
And if
Yes.
the
Boil
hemoglobin has not
anastomosis
dropped,
also, sir. One point is there. Boil anastomosis, if leak is there, then also it will increase.
exactly, but
Interboil anastomosis.
then they'll see whether it's a silent abdomen or whether peristalsis are still there or not. You can take X-ray abdomen in a standing position and see multiple fluid levels and all these things. That
Mm-hmm.
means there is obstruction. It can be paralytic ileus.
Yes.
Then see, check your electrolytes. See
Yes.
everything. Blood. So
Yes.
most important thing is clinically your gut feeling. Okay, and see, and then
Yes.
decide.
Yes.
Then, so how will you manage it? And then, as you said very rightly, you like to see the stoma also, the color of stoma also. And then
Yes.
you would like to see the output. And
Yes,
what is
sir.
the color of
Output.
that urine?
And serum creatine we have to check, sir. It
You
should
put, do
come
you put
within
Riles tube
normal.
also? Do you put the Riles tube also?
Sir, in stoma we usually
Not,
not
not
keep, sir.
stoma, Riles tube
Sir, Riles
during the
tube.
surgery.
Sir, we will keep, sir. Riles tube output. Meaning, we will do aspiration gastric, so that gastric fluid should come out, sir.
Okay. So how will you manage it?
Sir, then if no discoloration is there, if still abdominal girth is meaning, expanding, if ultrasound and X-ray all are normal, we will go for CT, because CT will more tell about any what is going on. So CECT abdomen.
Okay. So everything is normal. Now what you want to do? There is no leakage. Of course, CT scan is saying that the contrast has not yet reached to the, like it is still in the small bowel.
Sir, then
And
we
it is
should
less than
suspect.
4 centimeter. The dilatation
Mm,
of the loop is less than 4 centimeter.
Sir, then we'll suspect paralytic ileus or any kind of obstruction, sir. And
So after how many days of ileus you will suspect obstruction?
sir, after 3 days.
So during these 3 days, what
Usually,
you will do?
after 3 days, bowel should come.
Yeah.
Meaning,
So what you will
ileum
do?
should come.
So during this time, what you will how will you manage it?
So we'll keep as we'll keep aspirating the gastric fluid secretion, sir, and
Okay.
then volume management we have to do,
Okay.
keeping patient NBM, and that total parental nutrition we have to keep, sir, and uh, albumin we have to give for better wound healing, and mm,
And correct the
we
potassium. Na?
anemia we have to rule out. If any anemia
That's
is
okay.
there, we should.
But
uh,
potassium also you will do the correction. Na?
yes, serum electrolyte. If it is abnormal, then we have to do correction. Like,
No, no. So after 48 hours, you will not like to replace potassium.
sir, we will check serum electrolyte. If serum potassium is low, then we will give supplementation.
No, but if the patient is nil by mouth and you're not giving total parental nutrition, you have to, after 48 hours, you have to replace no, potassium.
Yes, sir.
Yeah. Okay. Gite sir.
सर फर्स्ट
So,
फर्स्ट फर्स्ट ऑफ ऑल वो जो लड़के ने बोला था कैम्बेल में है तो है सर वैसा कि हाई ग्रेड ट्यूमर के लिए साइमल्टेनियसली टीआरपी एंड टीआरबीटी नहीं करना चाहिए. That is in the 13th edition of the Campbell, page number 3097. So that we have to correct ourselves first. And जो discussion जो चल रहा है वो अच्छा अच्छा चल रहा है sir. It's going well.
right. So now for 3 days, Atul, you have done
Yes, sir.
yeah, 3 days you have done the uh, observation. Okay. Now I am
Yes, sir.
giving you two scenarios. In the first
Yes, sir.
scenario, suddenly the drain is showing 500 cc of fluid collection. What are the causes?
Sir, it can be urine, sir. I would like to know the color, sir. How is the color?
Straw color, yellowish.
Straw. Sir, then it can be ascitic fluid also, and it can be urine also. So for that, we have to urine create to serum creatinine ratio. If it is more than 10:1, then it will be definitely urine, and then we have to intervene.
Even if it is more than 3 times, it can be mixed
Yes,
with the serum as well as the ascitic fluid and so it should be more than 3 times. Then that is definitely some leak. If it is
yes,
more
sir.
than 10 times,
This
yes.
is definitely,
And 20, and if
definite.
it is equal to urine, then there is no question. It is only urine
Yes,
creatinine. Okay, so
yes,
now one of our patient will show you later on. In one of our
mhm,
patient, it was leaking.
yes, sir.
And from the conduit, it was 1 liter, and from the drain, it was 1 liter, and it was proved that it
Yes,
is
sir.
definitely urine.
Anastomotically.
Yeah, no, it is urine.
Oh,
Now
yes, sir.
what will do?
Sir, per day drain output, how much is coming, sir?
1 liter, and from conduit also 1 liter, from drain also 1 liter,
Sir,
and both the
then we should
creatinine is
intervene.
same. Both the creatinine are same.
Sir, we should intervene, sir. Again, we have to explore it and see where it is leaking, and
How
again we
easy
have
it is?
to.
How easy it is? First of all, from where it is leaking, how will you find out whether it is leaking from right ureteric anastomosis, left ureteric anastomosis, or it is leaking from the closure of the conduit?
Sir, this ureteric catheter, we have kept that one removed or still there, sir?
No, DJ stents are still there.
Okay. So, sir, we can do one thing. We can have conduit scopy, sir. If
You
it,
think that it is a good idea to do it, and
sir, it will be less invasive. If we are re-exploring, then it will be more
Baba,
invasive.
you can't do CT scan.
CT scan already done, no, sir? This is.
No, CT scan was you're not say. So okay, so we do the CT scan. It is showing leakage,
Yes.
and it is showing
Sir,
that probably it
site
is
of leakage didn't told on CT scans.
no, because all the ureters and anastomosis, they are very nearby, so it was very difficult to find out.
Mhm.
Then you can just put a gentle contrast into the conduit and see. If it is leaking from conduit, we can immediately see. If it is
Sir,
leaking from
can
one
we
of the
do
ureters,
IVP, sir?
yeah,
IVP we
IBP
can
was
do.
done. IBP was done, but both the ureteric or anastomosis and everything was very nearby. So if it sometime it becomes very difficult, the
Hmm.
contrast, but still, yeah, we were able to find out that it is leaking from one of the ureter. Okay,
Yes.
that is why one ureter was draining well, conduit was absolutely fine, and that is why 1 liter was coming from the conduit and 1 liter was coming from the drain.
Yes.
So now what you will do?
Sir, one option is we can keep PCN in that kidney and which
But suppose
ureter
if
is
you do,
leaking.
oh, it was okay, it was the right ureteric orifice anastomosis leaking. If I
Yes.
put only on the right kidney, but still there is a hole in the conduit, na? So idea is to do both the side PCM.
Oh, yes.
Okay,
Yes.
because the leak is not from the higher part of the ureter. It is at the
Yes.
anastomotic. Anastomotic means
Hmm.
again conduit only. So even the left
Yes.
ureteric fluid will keep on coming out, na?
Hmm. Yes, sir.
So do bilateral PCN. Okay, we did bilateral PCN, and that patient after about 48 to 72 hours, it started regressing. I mean, it stopped. Now what will do?
Mm. So what stops, sir? Pardon?
Leakage stopped because
Leakage stop. Okay.
both the kidneys were draining, na? Both the
Yes, sir.
kidneys are
Yes.
draining, so it has stopped.
So then we'll follow the patient, sir. No need of any invasive procedures.
How many days? 1 day, 2 days, 3 days, 5 days, 10 days, 15 days, 20 days. What you'll do to the PCN? What you'll do to the drain?
Sir, from after 7 days, we can do nephrostogram from the kidney, sir, and we can see if contrast is not leaking. Then we can remove PCN and stunts
Remove
also we
PCN.
can remove. Stunts also we can remove. After removal of the stunt only we can tell about that, sir. So at least
Hey, Baba, don't do that. Best thing is wait. Normally, for if there is no leakage for more than 7 days, okay,
yes.
then best thing is to clamp one-sided. That is what we did. The non,
Mm-hmm.
the left-sided drain nephrostomy we stopped and saw.
Mm-hmm.
Yeah, patient had no pain, no distension, no leakage. Drain was still kept, even though it was negative, zero.
Yes, sir.
So we waited for 24 hours. Everything fine.
Yes.
We
Mm-hmm.
closed the right-sided nephrostomy.
Yes, sir.
Waited. Everything was draining very well. Okay, we had two options to
Mm-hmm.
remove the nephrostomy or just to keep it closed in case of emergency.
Yes.
Fine. We waited for another 48 to 72 hours. Nothing was coming. Everything was coming from the ileal conduit. So we removed the drain.
Yes.
And then later we called patients. Again, did the nephrostogram. Everything fine. Removed it.
Mm-hmm. Okay, sir.
Okay. But before
Yes.
that, what I have done is that I have
Mm-hmm.
changed it to the long-term DJ stent, so that anastomotic leak will become the stenotic and patient will have problems. So at least for next 6 months to 8 months, I don't have to worry.
So, but stunt will not prevent the stricture rates.
No, but at least immediately stricture will not be done. It will keep on draining. Na? I don't want to do intervention again and again. And then will after 6 months to 8 months, once everything settles down, you have got some time to recover and decide what you want to do. So the another scenario, we have actually we wanted this case we have discussed last time, but the new case suddenly after 15 days patient came with no fluid coming from the ileum conduit, and she said
Yes.
that she is passing fluid per rectum. What is your diagnosis?
Per rectum. Mm.
What is your diagnosis?
Sir, mm, meaning like fluid he's
No, yeah,
passing.
fluid with the stool, and she is passing every half an hourly, 1 hourly. She is passing fluid,
Mm.
and nothing is coming out from ileal conduit.
Then, sir, antibiotic diarrhea we should rule out first, basic.
Okay, everything fine.
Mm.
We gave her enough of fluid. She was
Mm.
well hydrated. Everything fine. She is
How much
eating.
is serum creatinine, sir?
Serum creatinine normal.
Okay.
All the parameters are otherwise normal. Only thing is that she had mild tachycardia, 100 to 104.
Mm-hmm.
No abdominal distension, no pain in the abdomen, nothing. Hemoglobin also 9.5, not decreasing.
That ileal conduit only, no? So, no operation.
Yeah, patient was operated for ileal conduit. For 15
Mm-hmm.
days, she was passing urine from ileal conduit. She was actually discharged and then she came back.
Is there any prolapse of stomal prolapse or stromal hernia we should rule
But
out,
Baba,
sir?
nothing is coming out from this thing, na? Patient is passing
Okay.
everything through this rectum.
Mm-hmm.
So okay, I'll tell you. We sent that fluid for the creatinine again, like a
Yes.
drain. Everything was
Mm-hmm.
out, drain when everything was out,
Mm-hmm.
and it turned out to be urine. Now what you will do?
Now you think how that urine will go inside the rectum.
Sir, female then,
So what must have happened
sir, fistula might be there, sir.
between what?
Uh, Meaning colo meaning bowel adhesions might be there, and
So which are the places?
ileum and the native colon, wherever, because we don't know. So intra-bowel adhesions
Hey
and then
Baba,
fistula, sir.
you've done the ileal anastomosis also, na?
That's what, sir. Ileal conduit with ileal, meaning
Yeah.
that one.
So probably it must have been got adherent from the ileal conduit, the suture
Yes,
side and the anastomotic site of the ileal anastomosis.
yes,
And that is why she was passing fluid. Now what you will do?
yes, sir.
Very,
So,
very rare complications, sir.
Yeah, very.
uh,
Actually, unfortunately, that case we have prepared, but now we are not getting the. Uh, I will go to and I will put it on a group. You know,
Yes.
sir, we
so
have
we
to
had a two
divert.
options. I'm giving you the option, beta. One option
Yes,
was
sir.
again to do PCN. Another option is just to forget it. Let the
Sir,
patient settle
it
down
will
after
depend upon
one
the
month.
how much is the size of the fistula, sir. If it is high output fistula, we have to treat it. If it is low
No,
output,
no, it
and
is just internal, and it is just an internal, na. It is
Mhm.
like doing the sigmoid ureterosigmoid anastomosis.
Yes, sir.
And patient is otherwise okay. Patient is now eating, everything is okay. No pain, no fever, no vomiting now. Now to
So
go
then we can
inside
wait.
and do. Yes, so we decided not to do PCN. See, another option is again to do PCN and let it
Yes.
heat,
Mhm.
or just
Hey,
to wait.
sir, for general
Yeah.
in general surgery principle is whenever there is a takedown of any anastomosis, we have to explore and redo the anastomosis. That is
Yes.
very important thing everyone should keep in mind.
Yes.
ये अगर यूरिनरी सिस्टम का कोई लीक है, प्रॉक्सिमल डाइवर्जन करना है, तो वो यूरोलॉजी में पॉसिबल है. लेकिन जनरल सर्जरी में कोई भी एनास्टोमोसिस अगर ये टेक डाउन हुआ है या ओपन हुआ है, तो उसको
Yes.
कंजर्वेटिव ट्रीटमेंट यूजुअली प्रिफर कोई नहीं करता है. दे हैव बिकॉज इट इज बिलियरी पेरिटोनाइटिस, वेरी डेंजरस पेरिटोनाइटिस. वो बाद वो लीक रहे तो होता रहेगा, आदमी चला जाएगा, तो एक्सप्लोर करना पड़ेगा. ये पर्टिकुलर केस में अगर वो पर रेक्टली यूरिन पास कर रहा है, तो वो कहाँ से गया है, समझो फॉर एग्जांपल आर्डेजन भी हो गया, आर्डेजन होके वो खुल गया, रेक्टम रेक्टम आर्डे वहाँ चिपक गया, तो रेक्टम क्यों खोलेगा? बिकॉज दैट इज नॉर्मल सिरोजल. मुझे क्यों हो गया है मुझे अभी तक तो मैं जज नहीं कर पा रहा हूँ, लेकिन अगर हो भी गया हो ऐसा होगा तो एक्सप्लोरेशन करना पड़ेगा.
Yeah. So we had a three option, either to explore, correct. Second was to do diversion, means just put the nephrostomy on either side, or just patient was absolutely fine, so wait and watch.
Yes.
And so I thought that better we just wait and see how she is behaving, and didn't do PCN also. I don't every all the three options. Whoever says you may be right, because as Dr. Gite said, this is the first in my life I have seen something like this. So I didn't know
Yes.
what to do. Okay, and because patient was absolutely fine, tolerating everything, 1.5 hour, 2 hourly passing urine per rectal, we decided to wait. And I think in within 15 days to 3 weeks, the leak suddenly stopped. And now she is passing urine from conduit. So as Gite sir said, three things. If you are suspecting, go inside, explore and do the needful. Second option is to put a bilateral nephrostomy and then wait and watch, because there is no fistula coming into the ileal conduit. Otherwise, you
Mhm.
have to do something. Definitely exploration. And the third thing is what we have done. So I'll once I get the films, all this, na, I'll just put it onto the group.
Yes.
Fine. Maheshwari ji, आपको Azmi, you want to ask any question? I think that's over. Ganesh Bakshi was not here. Only thing is next Thursday
Sir,
probably.
sorry, मतलब I told Pankaj sir कि
Yeah,
genuine
yeah, yeah.
problem है. I just got free, मतलब वो
No,
palliative
no,
care
no
कर
problems.
रहे थे.
We understand, Ganesh.
Sorry.
Yes, yes.
Yeah.
I mean,
So
मुझे भी
Ganesh bhai,
पता है इनकी condition क्या है, but then some things I have to attend here.
no, I understand.
No problem.
100%.
Sorry.
Yeah.
Next time
So
you are
the,
planning CA penis ना मैं वो cases ढूंढ के रखता हूँ. and I think we'll go short case. आपके पास भी कुछ है तो आप भी थोड़ा
Yes, we have
करके
got
रखो।
4. Yeah, we have
हाँ,
got a 3 to 4 cases also.
चलेगा।
We'll keep it. Only thing is, I think next Thursday will be the first day of Visarjan, Ganpati.
Okay.
So, do you think we should change that date? This thing, instead of Thursday, we can do it on a Friday or something.
No problem, sir. Friday रखते हैं।
And that will
Friday.
be Maheshwari ji. What do you think?
I'm okay any date, sir. वैसे I don't think विसर्जन से हमें किसी को भी फर्क
हाँ
पड़ेगा।
सर, ऑनलाइन है तो ठीक ही है ना, चलता है
हाँ।
सर, बराबर बोल रहे पंकज सर।
Okay, then I will just see and decide. Huh?
Both is okay with me, sir.
Okay, fine. Gite sir, आपका क्या व्यू है?
सर आप जो भी दिन बोलेंगे वो मेरे लिए कोई प्रॉब्लम नहीं सर।
Okay, sir.
यस यस
Fine. Okay. Good night. Thanks to everyone.
गुड
Thank
नाइट
you,
Good
sir.
night, everybody. Gite sir, Pankaj sir,
Thank you, Hiren.
Ganesh bhai.
Sorry.
Bye. Good
Okay.
night,
Good night.
Gaurang
Good
sir.
night.
Atul, you are doing quite well. See, in the
And good
beginning,
night, Parth. We have learned something new today.
yes. And
Thank you,
Atul,
sir.
in the beginning,
Yes,
you
sir.
were quite different. And then at the end, just see, after 1 hour of the discussion, you became so fluent and so confident.
Yes,
This is what
initially I was
every,
quite nervous, sir.
पर
so
अतुल,
this is
एक
what
छोटा
every
सा
student
चीज
has to
मतलब ना,
learn.
मतलब
हाँ,
गौरंग
sir.
शाह सर और पंकज सर हमेशा बोलते हैं कि इफ यू हैव हर्ड दिस आल्सो एंड पिछले आल्सो, कि हर एक सवाल को ना एक 10 सेकंड्स 20 सेकंड्स देना एंड ट्राई टू
Yes, sir.
आंसर इट इन अ वेरी स्ट्रक्चर्ड मैनर।
And
मतलब
we
आपने ना वो बोला ना कि क्या करेंगे रेडिकल सिस्टेक्टोमी, तो ऐसा कभी उड़ी नहीं मारने का।
and
Okay,
we
sir.
would like to see your expressions, not your picture.
And एक बात बताऊं, मैं तो पंकज का एक्चुअली उसका एक्सप्लेनेशन का दीवाना हूँ। पंकज,
अभी देखो कैसा स्मार्ट लग रहा है अतुल।
really, Pankaj, I'm telling you, the way you explain how to answer in exam or anywhere, your clear thoughts are so clear and your sentences are so well structured. I think every student should, when they listen to you, they should learn this.
Thank you very much,
Thank you,
sir.
sir.
आपके साथ ही धीरे-धीरे क्लास में सीखे हैं सर कोई।
No, but it's
It
really
has been a gradual progression.
then good. Thank you very much, Ganesh. Thanks in spite of so
नहीं
many,
नहीं सर, मतलब वो
hidden.
करता हूँ मैं, अगले बार के लिए कलेक्ट करता हूँ सब, डोंट वरी।
Okay.
नाइट सर,
Chalo.
गुड नाइट।
Thank you
Right,
so
sir.
much, sir.
Good night.
Thank you, sir.
Bye, good night.
Thank you.